This video will be about multiple myeloma. And to begin with, we start with an introduction into plasma cell neoplasms. So let's just learn how a plasma cell is formed. So we have our bone with the bone marrow, and inside the bone marrow, we know that the lymphocytes develop into T and B lymphocytes. So bone marrow development occurs in the B cell development occurs in the bone marrow, and these B cells, they will differentiate into plasma cells, right? And what is the function of plasma cells? The plasma cells will give rise to the formation of immunoglobulins, that is Igs, and they play a role in the immunity of our body. Now, plasma cell neoplasm, as the term suggests, it is the neoplasm involving the plasma cells. So what happens when the plasma cells undergo neoplastic change? These plasma cells, they will secrete excess of immunoglobulins. So that is the first point. There will be excess Ig secretion. And secondly, along with that, what happens is that these secretions are abnormal. So we know that an immunoglobulin has a light chain. This is our light chain, and it has a heavy chain. So there are two heavy chains and two light chains. What happens in plasma cell neoplasm is that the light chains are excessively secreted due to abnormality. So there will be excessive light chain secretion. Light chain Igs will be secreted, and the immunoglobulins, they are produced by a single clone of plasma cells. So they are actually monoclonal Igs. And these monoclonal Igs in blood, they will aggregate to produce M protein. So these are some of the features which occur in a plasma cell neoplasm. That is, first, there will be excess secretion of monoclonal immunoglobulins. There will be defective secretion of light chain immunoglobulins, or the light chain part, and they will aggregate to produce the M proteins inside the blood. Now, the normal immunoglobulins, they are large enough and they are not filtered by the kidneys. But the light chains, what happens is that they are smaller in size and they get filtered in the kidneys. So they will lead to damage of kidney tubules. So there could be a renal failure could occur in plasma cell neoplasms. So that's the 4 points that we need to remember about, in general, about plasma cell neoplasms. Now, what are the types of plasma cells? We'll just learn the examples. One, we have the multiple myeloma, which we are going to discuss in this video in detail. And then we have the MGUS, that is the monoclonal gammopathy of undetermined significance. What it basically means is that these M components or M proteins are produced, they have in a moderate level. So it's not multiple myeloma, but it has a potential to transfer into multiple myeloma. And then we have the heavy chain disease. The heavy chain disease, as the name suggests, it's a group of disorders involving excessive production of heavy chains. And then we have the Waldenstrom macroglobulinemia. So Waldenstrom macroglobulinemia. Here what happens is that there is excess secretion of IgM into the blood. So defective IgM secretion is seen. So that's just a few examples. Now we move into our main topic in this video, that is multiple myeloma. So when do we call a plasma cell neoplasm as a multiple myeloma? So it's multiple myeloma is a plasma cell neoplasm. That's how we define the first point. And it is associated with, so plasma cell neoplasm associated with, there are 4 things. So our first point is the lytic bone lesions. So bone lytic lesions, which is our first point. And because of bone lysis, the calcium is released into the blood, leading to hypercalcemia. And then we had said that the light chains are filtered by the glomerulus and they damage the tubules, leading to renal failure. And these immunoglobulins, even though, as I have said, they are abnormal, they are not normal immunoglobulin. So they do not perform the normal immune function. So the person will have decreased immunity. So these 4 features, a plasma cell neoplasm with these 4 features indicates multiple myeloma. So bone lytic lesions, hypercalcemia, renal failure, and decreased immunity. Now let's move on to the etiopathogenesis. So we know that cancer occurs due to mutations, right? Now what causes mutations? What are the reasons for the mutations in a plasma cell, in a multiple myeloma? So there could be genetic factors. The mutations could be inherited, or it could be due to ionizing radiations. It's the usual etiology for all mutations, it's common. Or it could be due to chemicals. And it could also be due to chronic infections. Chemicals and chronic infections. So these are usually, as we know, these are the usual etiologic factors for any mutation. Now, what are the genes which are involved? So the genes involved are, firstly, the IGH gene. The IGH gene is involved. Then the other one is the cyclin. We know cyclins are cell cycle regulators. So cyclin D1, D3 are involved. Then there is the TP53 gene, the tumor suppressor gene. We know about it. and we have the MYC gene. Now these two genes, that is TP53 and MYC, if they are involved, there is a poor prognosis. Whereas if cyclins are involved, the prognosis is better. So this indicates a better prognosis. These are a few genes which are involved. Basically mutations in that means the B cell will survive or evade apoptosis. So they will develop into plasma cells. So what happens here is that with all of these things, there is an increased secretion of IL-6. So what is IL-6? Interleukin-6 is a growth factor for the plasma cells. And these IL-6 is secreted firstly by the tumor cells and then by the the normal cells. So the resident plasma cells, they both will secrete IL-6, which will act as a growth factor, and they will lead to the formation of the myeloma cell. Now what happens? Here what happens is that the tumor cell, so it will cause bone resorption. And how does bone resorption occur? We know that normal bone contains two types of cells, right? There are osteoclastic cells and there are osteoblastic cells. So we have the osteoclast in the bone and the osteoblast in the bone. Roughly we can say that the osteoclast dissolve the bone, whereas the osteoblast, they form the bone. So bone resorption occurs when the osteoblastic activity is increased, whereas the osteoclastic activity is increased and the osteoblastic activity is decreased. So how does the tumor cell cause this? What happens is that the tumor cells will secrete a chemokine called as CCL3, and it will also activate the WNT pathway. So there will be modulation of the WNT pathway and the CCL3, and the CCL3 will increase the osteoclastic activity, whereas the WNT pathway will decrease the osteoblastic function. So the osteoclastic activity is increased osteoblastic activity is decreased, and there is net bone resorption. And this leads to the punched out lesions in multiple myeloma, giving rise to the characteristic punched out lesions on radiography. So that's about the pathogenesis. Now we move on to the morphology. So we know that in morphology we always discuss about the bone marrow and we discuss about the peripheral smear findings. So let's begin with the bone marrow, and we start with these questions. Cellularity, as we know, it's always going to be hypercellular. Now, what is the dominant cell? So it is our plasmas, tumor cells, right? They are called the myeloma plasma cells. Myeloma plasma cell. Now, how much percent are they usually present? They will be usually greater than 30%. Their cellularity is usually going to be greater than 30% in multiple myeloma. So this is our myeloma plasma cell. Let's describe it. As we know, their shape, they are oval shaped cells, and they have a pale blue cytoplasm, appendant blue cytoplasm, and they have the nuclei. If we look, it is eccentric nuclei. The position is not central, and it has a single nucleolus. There is a nucleolus, and here we have a perinuclear haloing, that is due to the Golgi apparatus. Perinuclear haloing is seen, and in addition to that, the chromatin has a spoke wheel pattern. So there is a spoke wheel chromatin as well. Spoke wheel pattern of chromatin. So what are the features? Let's say once again. So it's an oval shaped cell having a blue cytoplasm with a nucleus in an eccentric position with a nucleolus and perinuclear haloing with spoke wheel chromatin. The important points are again oval, eccentric nucleus, perinuclear halo, and spoke wheel chromatin. These 4 points must be noted about a myeloma plasma cell. And in addition to that, there are some other cells as well, some other types as well. So here we have the normal plasma cell. This is a normal plasma cell, and this has a single nucleus. There is the binucleate variant, as we can see here. There are two nucleus. So this is another abnormal form. So binucleate plasma cells may be seen. And then we have a plasma cell which inclusion bodies. So because of the secretion of abnormal immunoglobulins, what happens is that these immunoglobulins may be absorbed by the plasma cell itself. So they will give rise to a number of inclusion bodies. And depending upon the type of inclusion body, different types of plasma cells are there. So if the inclusion body of immunoglobulins are present inside the cell, these inclusion bodies are inside the cytoplasm. They are called as Russell bodies. So these are inclusion bodies of immunoglobulins present inside the cytoplasm. And if they are present inside the nucleus, they are called as Duscher bodies. These are inclusion bodies present inside the nucleus. And sometimes what happens is that crystalline matrix may be present or absorbed inside the plasma cell, crystalline proteins. And often what happens is that there will be several Russell bodies or several inclusions, and this will give the appearance of a grape. Grape-like inclusions are seen inside the myeloma cell, and such a cell is called as a moat cell. So it is called as a moat cell. So these are actually the different types of cells which are present, which are seen in the bone marrow examination of multiple myeloma. So we have our myeloma plasma cells, we have our moat cells, we have the binucleate variant, and we have inclusion bodies. It's nuclear, it's Decho bodies. If it is cytoplasm, it's called as the Russell bodies. Or there could be other crystalline proteins and fibrils or globules which may be present as inclusion bodies in the myeloma plasma cell. So that's about the type of dominant cell. Now moving on to the erythropoiesis. As we know, because of marrow infiltration, the erythropoiesis will be decreased. Myelopoiesis, initially it will be normal, but then as the marrow infiltration worsens, it will start to decrease. The same with the case of megakaryopoiesis as well. Initially it will be normal, and with further progression of disease and marrow infiltration, it will get decreased. What about the peripheral smear? So peripheral smear, what happens is that because of decreased erythropoiesis, there will be anemia, right? Now the anemia is usually of the normocytic normochromic. There is no reason to be a microcytic or megakaryocytic. So it's going to be normocytic normochromic anemia. And the feature about RBCs is that there will be rouleau formation. Now why does the rouleau formation occurs? We will discuss that once we move to the clinical features. Basically it's because of increased M proteins. So we said that these M proteins have a tendency to aggregate, and that causes the RBCs to stack against one another, stick to each other, and lead to rouleau formation. Now coming to the WBCs, initially as we said, it is going to be normal, which may decrease with decrease in myelopoiesis. The same applies to platelets. They're usually going to be normal. Now moving on to the clinical features. So the clinical feature of multiple myeloma is actually due to 3 reasons. So there are 3 reasons which we need to know. The first one is marrow infiltration, and the second reason is due to the excessive M proteins, or because of the monoclonal antibody production, symptoms due to them. And third one, it is due to decreased humoral immunity. So the immunoglobulins are abnormal and they do not act normally. So what are the features due to marrow infiltration? As we said, they cause lytic bone lesions. So the first one is going to be bone lesions, that is bone lysis, and bone lysis will present as osteoporosis, and fracture of bone will occur. Pathological fracture of bone will occur. And because of this osteoporosis and fracture, what happens is that there will be hypercalcemia. The calcium is released from the bone into the blood. That will lead to hypercalcemia. Now, what are the features of hypercalcemia? Hypercalcemia will present with CNS features, and it will lead to muscular features, renal features. So in renal, we start with CNS. There will be signs of confusion, drowsiness, lethargy. And muscular, there will be weakness of the muscles. And renal, there will be increased urinary excretion. So there will be polyuria. These are the consequences of hypercalcemia. Now osteoporosis and fracture, we said, right? They will present, as we have said earlier, punched out lesion in the X-ray. Now which bones are involved? Usually the axial skeleton is involved. So the axial skeleton, most commonly the vertebrae is involved, and then the ribs, then we have the skull. So the bones that are present on the axis of a body, they are usually involved. Now the features due to the monoclonal M protein. As we had said, these monoclonal antibodies, they will pass out through the kidney and they will cause renal failure. So they are toxic to the renal tubular cells. They are filtered by the glomerulus. They are toxic to the renal tubular cells. They will damage them, leading to renal failure. And they will aggregate inside the blood. These M proteins will aggregate and increase the viscosity of the blood. It will lead to hyperviscosity. These Ig proteins also have a tendency to aggregate and cause amyloidosis. They will misfold and form AL amyloidosis type. So these are some of the features which occur due to the monoclonal protein. Now the M proteins, as we have said, they are filtered by the kidney, right? So they will cause renal failure and they get excreted out in the urine. And these light chains which are excreted out in the urine, we know what they are called. Very famously, they are called the Bence-Jones proteins. So Bence-Jones proteinuria is a very typical sign that is seen in multiple myeloma. Now moving on to some of the other things which we have forgot to tell. That is, as I have said, them proteins cause rouleau formation, as I have said earlier, because they will cause the RBCs to stick to each other. Now let's move on to the third part, that is decreased immunity. Of course, we know that infections will increase. So these infections, it could be pneumonia, meningitis, a lot of them, or it could be pyelonephritis affecting the kidneys. And if pyelonephritis occurs, again what happens is that it will further worsen the kidney function, leading to renal failure. So we have a syndrome complex, right? It might look a bit hard to understand all of this, but the concepts are really simple. If we think from these 3 points, that is marrow infiltration, M protein, and decreased immunity. When the immunity is decreased, infections such as pneumonia, pyelonephritis will occur. Pyelonephritis will lead to renal failure. And when marrow infiltration, there will be lytic bone lesions which will present as pathologic fracture or osteoporosis involving the axial skeletons, and it is seen as punched out lesions in X-ray. And they will release the calcium from the bone, hypercalcemia. So then we have to think about features of hypercalcemia, which could be lethargy, muscle weakness, polyuria. And when the M proteins, when they are toxic to the renal tubules, they get excreted as Bence-Jones proteins. They stick to each other, leading to rouleau formation. They have a tendency to develop into amyloidosis, and they cause hyperviscosity. So that's how you remember about the clinical features. Remember the first 3 headings, and then you can get the concept yourself. Now moving on to the part of laboratory diagnosis. So the lab diagnosis is usually at we need 2 elements. First one is the bone marrow examination. We have said we'll see plasma myeloma cells. They are usually seen greater than 30%. But according to the criteria, the International Myeloma Working Group criteria, the plasma percentage of cells can be, or the myeloma cells, greater than 10%. 10% is what they use for diagnosis, and it is not 10% alone. CRAB criteria, sorry. So what is the CRAB criteria? So if you have a myeloma cell of 10% in bone marrow plus 1 of CRAB, so what is C? C is hypercalcemia, calcium. And what is R? R is renal failure. Renal failure. What is A? We know that production of RBC is decreased, so A is anemia. And what is B? B is bone lesion. Now hypercalcemia, what is the cutoff value? It is going to be greater than 11 milligram per deciliter. And then the renal insufficiency. How do we know about renal failure? We look for urea, we look for creatinine, and there will be the Bence-Jones protein in urine, BJP. Now creatinine, the cutoff is greater than 2 milligram per deciliter. It's usually 0.7 to 1.4. So if it's greater than 2. Then about anemia, as we know, we look for the hemoglobin level and we look for the RBC level. It's going to be a normocytic, normochromic anemia. And in bone lesions, as we have said twice already before, punched out lesions in the axial skeleton. So if you have a myeloma cell of greater than 10% plus 1 out of the 4, 1 by 4, any one of the 4, we diagnose it as multiple myeloma. So 1 or greater than 1 of the 4. Now what is the treatment? So to know the treatment, we need to know about the role of proteasomes. So proteasomes do the function of degrading misfolded proteins or misfolded immunoglobulins, whatever it is. If you inhibit the proteasome, what happens? When the proteasomes are inhibited, there will be misfolded proteins or misfolded immunoglobulins, abnormal immunoglobulins inside the cells, inside the plasma myeloma cells, and they will trigger apoptosis. So they will trigger apoptosis and cause the death of multiple myeloma cells. So proteasome inhibitors are one choice of drugs. The example for these include thalidomide, and then there is its derivatives, that is lenalidomide. These are the drugs that are usually used for the treatment of multiple myeloma. Now moving on to the prognosis. The prognosis of multiple myeloma, it's usually variable. And usually the patient survives 4 to 7 years. That is the median survival rate. 4 to 7 years is the median survival rate. Without treatment, the patient will die within 6 months. So 6 months, with indicating a really poor prognosis. And worst prognosis is associated with MYC mutation and TP53 mutation. In the beginning, we had said about this. Better prognosis, that is 4 to 7 years prognosis, is associated with the cyclins, that is cyclin D1 mutations and D3 mutations. So that's about multiple myeloma, and that's in a nutshell about the plasma cell neoplasms.